Good evening to one and all present here. Respected President, sir, Honorary State Secretary, sir, our immediate past President, Dr. Madhusudan, sir, and our moderator, Dr. H.E. Ramaraju, sir, and all the other attendees who have joined us through Zoom as well as through YouTube. It gives me immense pleasure to welcome you all on behalf of IMA KSP and IMA MSN Karnataka. It gives me immense pleasure to initiate with today's session as with the hope that this is one of the major vital academic sessions which is initiated by IMA KSP in order to streamline the students, the upcoming examination to motivate the students and to aid them in the clinical case presentations. I hand over to Pooja for the further introduction. After this, we'll begin with the IMA prayer.
Good morning. Good evening to. Yes, am I audible?
Yeah, we can hear you.
Yes. Any disturbance? Yeah. Should I
go
start?
ahead. You go ahead. You go.
Yes,
Audible.
sir.
Go ahead.
Yes, sir. Yes. Yes, sir. Good evening to everyone present here. Good evening, sir. Good evening, ma'am. I'm Pooja Patil, State Co-Convener, IMA MSN Karnataka. Today, we are at the launch of our brand new case presentation series, where you'll get to learn from the top, most excellent set of moderators and the best student representation from various colleges of Karnataka. This initiative was taken by State Council IMA KSB, IMA MSN Karnataka 2022-2023 Council to enhance and help students to get the most comprehensive and extensive knowledge through clinical cases. I would like to hand over for Mithun to start the prayer.
Yeah, thank you, Pooja. Yeah. Now we will start with our IMA prayer. I request you all to recite after me. We'll begin it. Okay. May everybody be happy.
May everybody be happy.
May everybody be healthy.
May everybody be healthy.
May everybody be free from pain.
May
May everybody be free from pain.
May everybody be free from sorrow.
May
May
everybody be.
everybody be free from
May
sorrow.
we be the healing cure
May we be the healing cure
beyond
Healing
every
cure.
greed and love.
beyond every.
Beyond every.
Thank you. Jai Hind, Jai IMA, long live IMA.
We are here today beginning our very first session on this how to approach a OBGYN case, where we will be discussing a case on previous LICS.
Pooja, one
I
minute.
welcome our moderator.
Pooja, just 1 minute. Our state IMA president, Dr. Shivkumar B. Lakol sir, has joined the session virtually. We welcome you, sir, on behalf of IMA KSB and IMA MSN Karnataka. Welcome you, sir.
Lakol sir.
Yes, sir.
ಕೇಳುತ್ತದ
I would like to.
We can
Yes, sir.
hear
Yes,
you.
sir. It is. Sir.
ಕೇಳುತ್ತಲ್ಲ ಮಿಷನ್
Yes, sir.
ಓಕೆ ಓಕೆ ಎಲ್ಲರಿಗೂ
Yes.
ಸಂಜೆಯ
I would.
ನಮಸ್ಕಾರಗಳು. ಅಕಾಡೆಮಿಕ್ ಸಬ್ ಕಮಿಟಿ ಅಧ್ಯಕ್ಷ ಚೇರ್ಮನ್ ಆಗಿರ್ತಕ್ಕಂಥ ಸಂಜಯ್ ತಲ್ಲೂರ್ ರವರೇ ಹಾಗೂ ಸಬ್ ಕಮಿಟಿಯ ಎಲ್ಲ ಮೆಂಬರ್ಸ್ ಆಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಹರೀಶ್ ತೆಲಂತಬೆಟ್ಟು, SM ಪ್ರಸಾದ್, ಡಾಕ್ಟರ್ ಪ್ರೀತಮ್ ಮುರ್ಕಡ್ಲಿ, ಡಾಕ್ಟರ್ ಅರ್ಜುನ್ ಅನಿಮೇಶ್ ಜೈನ್, ಡಾಕ್ಟರ್ ಗೀತಾದಪ್ಪ ಹಾಗೂ ಡಾಕ್ಟರ್ ದೇವಕರ್ ರೆಡ್ಡಿ ಅವರ ಮೊಟ್ಟ ಮೊದಲನೆಯ ಈ ಕಾರ್ಯಾಗಾರ MSN ನೆಟ್ವರ್ಕ್ ಮೆಡಿಕಲ್ ಸ್ಟೂಡೆಂಟ್ಸ್ಗೆ ಅನುಕೂಲವಾಗ್ತಕ್ಕಂಥ ರೀತಿಯಲ್ಲಿ ನುರಿತ ವೈದ್ಯರನ್ನ ಕರೆಸಿ ಮಕ್ಕಳಿಗೆ ಬೇಕಾಗಿರ್ತಕ್ಕಂಥ ಕೇಸ್ ಪ್ರೆಸೆಂಟೇಷನ್ನು ಮತ್ತು ಅನೇಕಾರು ಅಕಾಡೆಮಿಕ್ಗೆ ಯೂಸ್ ಆಗ್ತಕ್ಕಂಥ ವಿಷಯಗಳನ್ನು ಮಂಡಿಸ್ಲಿಕ್ಕೋಸ್ಕರ ಈ ಮೊಟ್ಟ ಮೊದಲನೇ ಕಾರ್ಯಕ್ರಮವನ್ನು ಹಮ್ಮಿಕೊಂಡಿದ್ದಾರೆ. ಅವರಿಗೆ ನಾನು ಶುಭವಾಗಲಿ ಅಂತ ಈ ಸಂದರ್ಭದಲ್ಲಿ ಹೇಳ್ತೀವಿ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಅನೇಕಾರು ವಿವಿಧ ಕಾರ್ಯಕ್ರಮಗಳನ್ನು ಹಮ್ಮಿಕೊಂಡಿದ್ದು, ಹಾಗೆ ಮೆಡಿಕಲ್ ಸ್ಟೂಡೆಂಟ್ಸ್ಗೆ ವಿದ್ಯಾರ್ಥಿಗಳಿಗೆ ಅನುಕೂಲವಾಗುವ ನಿಟ್ಟಿನಲ್ಲಿ ಅಕಾಡೆಮಿಕ್ ಸಬ್ ಕಮಿಟಿಯು ಉತ್ತಮವಾದಂಥ ಕಾರ್ಯವನ್ನು ಹಮ್ಮಿಕೊಂಡಿದೆ. ಆ ನಿಟ್ಟಿನಲ್ಲಿ ಇವತ್ತಿನ ದಿವಸ ತಜ್ಞ ವೈದ್ಯರಾದ ಡಾಕ್ಟರ್ H.E. ಹೇಮರಾಜ್ ಅವರು ಅಸಿಸ್ಟೆಂಟ್ ಪ್ರೊಫೆಸರ್ ಬಳ್ಳಾರಿ ಅವರನ್ನ ಕರೆಸಿ ಯಾವ ರೀತಿ ಕೇಸ್ ಪ್ರೆಸೆಂಟೇಷನ್ ಮಾಡಬೇಕು ಅಂತೇಳಿ ಅವ್ರನ್ನ ಮಾಡರೇಟರ್ ಆಗಿ ಇಲ್ಲಿ ಬಂದಿದ್ದಾರೆ. ಅವರಿಗೆ ಸ್ವಾಗತವನ್ನು ಕೋರ್ತೇನೆ. ಹಾಗೂ ಕೇಸ್ ಪ್ರೆಸೆಂಟೇಷನ್ ಮಾಡ್ತಕ್ಕಂಥ ಶ್ರೀನಿವಾಸ್ ರೆಡ್ಡಿ ಅವರಿಗೆ ಒಳ್ಳೆಯದಾಗಲಿ, ಚೆನ್ನಾಗಿ ಕೇಸನ್ನು ಪ್ರೆಸೆಂಟರ್ ಮಾಡಲಿ ಅಂತೇಳಿ ಈ ಸಂದರ್ಭದಲ್ಲಿ ಹೇಳ್ತಾ, ನಾನು ಬೇರೆ ಮೀಟಿಂಗ್ ಒಳಗಿರೋದ್ರಿಂದ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಬಂದಿರತಕ್ಕಂಥ ಪಾಸ್ಟ್ ಪ್ರೆಸಿಡೆಂಟ್ ಹಾಗೂ ಮಹಿಳಾ ಕಮಿಟಿಯ ಚೇರ್ಮನ್ ಆಗಿರ್ತಕ್ಕಂಥ ಮಧುಸೂದನ್ ಕಾರಜನೂರ್ ಅವರಿಗೆ ಸ್ವಾಗತಿಸುತ್ತಾ, ಈ ಕಾರ್ಯಕ್ರಮ ಯಶಸ್ವಿಯಾಗಲಿ, ಹಿಂಗೆ ಮುಂದುವರಿಲಿ ಅಂತೇಳಿ ಅಕಾಡೆಮಿಕ್ ಕಮಿಟಿಯ ಚೇರ್ಮನ್ ಎಲ್ಲ ಮೆಂಬರ್ಸ್ಗಳಿಗೆ ಮತ್ತೊಮ್ಮೆ ಧನ್ಯವಾದಗಳು ತಿಳಿಸ ನನ್ನ 2 ಮಾತನ್ನ ಮುಗಿಸ್ತೇನೆ. ನಮಸ್ಕಾರ. ನಮಸ್ಕಾರ ಸರ್.
ನಮಸ್ಕಾರ.
I humbly welcome you, sir. Thank you, sir, for your gracious presence today. I also welcome Dr. Karunakar, sir, Honorary State Secretary. I also welcome Dr. Madhusudan, sir, immediate past President, IMA KSB. I would like to humbly welcome them and thank them for their time today.
Karunakar sir. A few words. Being a professor of pediatrics, he is a professor of pediatrics from MS Ramaiah Medical College. He is our honorary secretary. We'd like to have few wisdom of words for the students, being a teacher. Please.
Sir, thank you so much. Good evening, everybody. On behalf of IMA KSP and IMA MSN, it's a great initiative to really start this training program for the students. We look forward to see that the IMA does enough meetings to see that our students are well trained. The experience of the faculty should help students to learn various aspects of clinical medicine. And we are looking at some point of time, we do a much better or a much extensive training with respect to student training through IMA KSB actually. As Dr. Madhusudan has said, as a teaching faculty, it's our privilege to really keep training students, and under the leadership of Dr. Madhusudan and the academic subcommittee and the MSN banner, we are going to provide a much better or maybe even much experienced faculties will also be included over a period of time. And I'm sure today Dr. Srinivas Reddy is going to do a wonderful job. And we promise to see that this program is continued. Only we request the students to disseminate the message to more and more students to participate so that it reaches to everybody actually. So with this, I would like to thank everyone of you once again. Thank you, sir. Thank you so much. It's back to you again. Thank you.
Thank you, Dr. Karunakar, sir. You rightly mentioned, today we are beginning our very first session on how to approach a OBGYN case, where we will be discussing on the case of previous LICS. I would like to welcome our moderator, Dr. H.E. Ramaraju, sir, Associate Professor, WIMS Bellary. We extend our hearty gratitude to you, sir, for your gracious presence today.
Thank you.
I would like to,
Thank you.
Yes, sir. Yes, sir.
Yeah.
Welcome, sir. I would like to welcome our presenter, Dr. Srinivas Reddy, final year MBBS from ESIC Kalburgi. I would like to call upon Chaturya to introduce our moderator for today. Yes, sir.
Good evening, everyone. Today we have here with us Dr. H.E. Ramaraju, Associate Professor, Department of OBG in WIMS, as our moderator for this discussion. Sir is the president of Ballari OBG Society. He is also the EC member of IMA Ballari and the zonal coordinator South Zone in the breast committee of FOGSI Mumbai. Sir has also won many awards such as the Professor Shan S. Ratnam Young Gynecologist Award by AOFOG Taiwan in 2011, to name a few. He has also published multiple research papers in national and international journals. His special interests include high-risk pregnancy, adolescent gynecology, and social obstetrics. Thank you so much, sir, for taking out your time from your busy schedule and to enlighten us with your knowledge. We're truly honored to be sharing the platform with you, sir.
Thank you, one and all, for the opportunity. At the outset, I would like to thank IMA Karnataka State Branch and IMA KSB Academic Subcommittee, IMA KSB Medical Student Network, and all the office bearers who have taken this wonderful initiative of educating the younger generation of doctors from the student level and bringing the consultants and bridging the gap between the students and the teachers. And I also special thank to Madhusudan Karinu sir for having invited me for this session. With this, a brief introduction, because previously, as far as the maternal health is concerned, we have finished the mission Moon and we have gone to the Mars. So, but very little has been done as far as the maternal health is concerned. So, United Nations is taking keen interest, and time and again they are setting certain health goals for to reach this one. Previously, we had MDG, Millennium Development Goals. They were set till 2015. So MDG 4 was dealing with the maternal mortality, and MDG 5 was dealing with the infant mortality. So as far as year 2015 was concerned, MDG goals were supposed to have met, but more than 70% of the countries could not achieve that goal. So from 15 to 30, they have taken an initiative as Sustainable Development Goals. So we have 17 development goals. Goal 3 deals with the good health and well-being. As we had initially the IMA prayer, where we deal with the IMA prayer is very apt with this goal of good health and well-being. Under that, by 2030, the maternal mortality of the world has to be reduced to 70 for 100,000 live births, and IMR should be brought to the level of 12 per 100,000 live births. So with this brief introduction, and I am happy to share this, most of the states of our country are still lagging behind, but a small country like Sri Lanka has attained a very good MMR of very less than 30, and I'm very happy to say that even our Kerala state has done a wonderful job, and Tamil Nadu, Karnataka has also fastly catching up with this development. We have already achieved that 70 per 100,000 live births. So with this background, I request the presenter to go ahead with this presentation.
Good evening, sir.
Yeah, good evening.
Sir, my name is Srinivas. I am studying in 4th standard in ESIC Medical College, Gulbarga, sir.
Okay.
My case is pregnancy with previous LACS, sir.
Okay.
Can I
go
start,
ahead with
sir?
your presentation.
Okay, sir. My next slide. Patient profile. Mrs. XYZ, she's a 27-year-old, a wife of Mr. XYZ, residing at Sedam, educated up to BSc, and she's a housewife. And her husband is a shop owner by occupation, and they belong to middle class according to modified BG Prasad's classification. And her nearest previous slide. And her nearest health facilities, PHC Sedam, which takes 15 minutes to reach by walking. Her obstetric score is.
Can I interrupt here?
Yes, sir.
Srinivas?
Yes, sir. Yes, sir.
Yeah. Why did you ask the time to reach her nearest PHC facility, health facility?
Sir,
how does it matter?
So in case like she had a last pregnancy, which was emergency, sir, due to oligohydramnios. She had to reach to hospital because of emergency condition. So for that it matters.
Yeah, you are very rightly said it, because when we analyze the maternal mortality, there was 3 delay module was there. So delay in taking decision. First of all, the patients or their attenders should decide to go to the healthcare facility to get her delivered. If at all they want to, they decide also they have to reach the health facilities. So that is delay in taking decision, delay in reaching the facilities, and most of the time, again, there is a third delay that can happen at the healthcare facility, where the resource poor settings, we are very much handicapped by the less of resources and more of the workload.
Yes,
okay,
sir.
so with this background, it is very important that a woman with high risk pregnancy should know her health facility, nearest health facility, where she can go to take the help if in case she needed. Okay, proceed with this one.
Yes, sir. Her obstetric score is Gravida 2, Para 1, and Living 1. her last menstrual period is, sir, I took this case before 1 week, sir, and her LMP was 15th March 2022, and expected date of delivery is 22nd December 2022. Her period of gestation was 37.
One second.
37.
Srinivas?
Yes, sir.
Okay. So what is the importance of EDD here?
Sir, we'll able to know when she'll deliver.
Okay, because it's what is this formula is called as?
Sir, Negligence formula.
Now, you are very rightly said. But how do they? Some women will say some LMP date, and based on that you apply this Negligence formula and you will get this date. But how reliable is this date? So how many do you think that they will deliver on this date?
Sir, only 20 to 30% will deliver.
Not so much. Only 4% will deliver on that given date. That what you have said here, 22 December. So most of the people will 95 to 97% will deliver 2 weeks earlier or 1 week later than your expected date.
Yes,
provided. So, but after calculating the CDD, we can say these dates as poor, good, or excellent dates. So how can you quantify this? Have you heard of this terminology?
Like 40 weeks.
No. What EDD you have got, no? After getting the CDD, you can categorize this into 3 dates, because this EDD is calculated based on her date, what she has given.
Yes,
so
sir.
After calculating that EDD date, you can say it as a poor date. She has got poor dates, good dates, or excellent dates based on because you can have a reliability of this EDD is very, very reliable only when she has got regular cycle. Okay.
Yes, sir.
Regular
Yes,
cycle
sir.
means, can you tell me the characteristic of a regular
Yes, sir.
cycle?
28 to 31 days cycle, sir. 4 to 5 days of flow, and she changes 1 to 2 pads per day. No clots are seen.
Yeah, you're very rightly said, but we are very fond of number of weeks in obstetrics and gynecology. So you can say roughly as in 3 to 5 weeks. So 3 weeks
Yes,
is 21 days to 35 days. So each woman is unique, and every woman has got their own cycle length and intercycle days and number of days of flow and work. So roughly that is everything falls in range between, that is 3 to 5 weeks of menstrual duration. Okay, and
Yes,
and she should not have. So any woman getting cycle every 21 days, 20 days, or 22 days, it's okay. But if the same woman is getting the cycle, one cycle 20 days, one cycle 40 days, one cycle 60 days, it is irregular. So
yes,
the LMP given by such woman is very going to be definitely, EDD calculated by woman from that date will be more of a poor one, and she should not have taken contraceptions in the previous 3 cycles prior to getting pregnant. Okay.
Yes, sir.
So, and she'll be having regular cycles and no contraception prior to 3 months prior to her conception. So such woman as so the EDD calculated by from such woman is very good. So it's called as an excellent date. Okay, proceed. Why is it important? Because why is it important? At the end of the day, why are you calculating this one?
Sir, to prevent maternal complication, like if she before only come to know,
maternal complication is a secondary thing, but what is the end result of this calculation? What are you achieving?
To normal vaginal delivery.
No. Before normal vaginal delivery, what are you calculating here? Dates means gestational age.
Yes, sir.
So we're arriving at what is the probable gestational age of this pregnancy, index pregnancy. Okay.
Yes.
Why is it important, gestational age?
Sir, normal growth and development before 32 weeks, the baby is not fully developed.
You're right. Because gestational age is important because in high risk pregnancy, as far as the normal thing goes, we say the term gestation is between 37 to 42 weeks.
40 weeks, yes,
but
sir.
Yeah, so there is a huge range, almost 5 weeks range is there. from the start to the end of that normalcy. But when it comes to high risk pregnancy, like previous cesarean section, hypertensive disorders of pregnancy, and this and so many other conditions, where you do not have to wait till the 37 weeks term.
Yeah.
So
Yes, sir.
you may have to intervene her to save the baby and the mother at their earliest. Like in eclampsia,
Eclampsia. Yes,
both for
sir.
the maternal and fetal indication. Sometimes in IUGR and severe IUGR and other cases, in the fetal interest, we have to go for a fetal distress. We have to go for an early intervention. So there, the importance of gestational age comes. So willingly, we should not take out a very premature baby by calculating wrong dates or this one gestational age. So and that babies will end up in NICU for 1 or 2 months, and the medical bill runs to lakhs of rupees, and there is no point in giving such moribund or NMR babies by just merely not looking into the gestational age. You got it?
Yes, sir.
Yeah. So that is the importance of gestational age, to calculate the approximate, not 100%, but still very close to that one. Okay.
Yes, sir.
Proceed.
Next slide, ma'am.
Srinivas?
Yes, sir. Her presenting complaints is gravided to para 1 and living 1, and she is at 37 weeks or 4 days of gestation, came for safe confinement of her pregnancy and admitted in view of previous cesarean section and no other complaints.
Can you tell me? Hello, can you go
Yes,
back to the
yes,
previous?
sir.
Yeah. Why has she come at 37 weeks of gestation?
Sir, like regular ANC visit, she came, sir, for safe
Okay.
confinement, and
So,
she also has fear of
can you,
previous.
for the benefit of the audience, can you tell me what is the regularity of antenatal visits proposed by Government of India?
Minimum, sir.
Not minimum.
Minimum.
The regular one. If that is not complaint, then we will go to minimum. Given the chance, we should have a maximum. What do you say?
11 to 14 visits are needed.
Yeah.
Like
so how often?
up to 7 months.
Yeah.
Up to 7 months, every month one visit
Very
should
good.
be there, sir.
Okay.
8th month, every 15 days one visit, and 9 month every week one visit.
9 months means beyond 36 weeks. So
Yes, sir.
I already said in the start of the
Yes, sir.
gestation, it is better
You
to
should.
because patients, they say in terms of months, so we are very fond of weeks, because each week is very important in our obstetrics and gynecology. Okay.
Yes,
so
sir.
many things are going to happen in on a week basis. So up till as you said, 8 months, that is 36 weeks. Why? Because after beyond 36 weeks, she is going to next week. She is going to term 37, entering the term. So that's the reason we are calling her every week after 37 weeks. So that's very right.
Yes, sir.
Okay, because she is a case of previous section. What are you worried about?
So like previous section, she went for cesarean section due to condition called oligohydramnios, sir.
Okay.
It
Can
is
you
not
name
a,
the indications for cesarean section?
sir, like absolute indications and relative indications is there, sir.
Very good.
An absolute indication, there is no like trying for vaginal delivery. We should always go for cesarean section, sir.
Very
like
good.
contracted pelvis, cephalopelvic disproportion.
Yes.
More than true.
Is CPD absolute one?
Sorry, relative.
Yeah, you are right.
More than
Because
two.
contracted and CPD, contracted is if the woman has a contracted pelvis, it is contracted for life.
Yes, sir.
Got it. CPD is a relative terminology. In one pregnancy, she might have a CPD. The next pregnancy, she might not have CPD. Mean to say, because CPD is a cephalopelvic disproportion. Sometimes the average size pelvis of a woman can harbor, average size baby she can deliver. Or for a average size pelvis, the baby is big, beyond 3.5 weight of 3.5 kg to 4 kg plus, like microsomia. That becomes a CPD case.
Yes, sir.
Sometimes what happens, the baby can be small. Okay.
IGRBG.
Vice versa can also happen. So that's the reason CPD is not an absolute one. It is a relative terminology. Okay.
Sir, other like previous 2 LSCS or previous 3 LSCS is a absolute indication for LSCS, sir.
Okay.
Like relative indications like polyhydramnios, oligohydramnios, any medical conditions like preeclampsia, gestational diabetes mellitus.
Okay.
Those all are relative indication for LSCS.
Okay. Do you think that because she has got her discharge slip with her previous?
No, no, sir.
So when you encounter a woman with previous cesarean section in antenatal OPD, what are all the things you would like to ask? Because history taking is one of the important aspect of medical, what do you say, medicine practice.
Yes, sir.
Okay. So we may have so many gadgets today there is nothing like taking a good history and clinical examination. Okay.
Yes.
Yeah. So what are all the things you would like to ask in a woman with a previous cesarean history?
Sir, like scar tenderness, scar.
Straight away scar tenderness? No. She has come for the first time to you.
Yes, sir.
Yeah. Scar tenderness, I agree. If she has come in, labor, late trimester, late third trimester, and if she has come in labor,
inspection of abdomen, any scar.
Elicit, yeah. No. At the history level.
Yes, sir.
So with regard to previous cesarean operation, what are the details you want to ask from her?
Yes, sir. Like whether this delivery, any more blood for PPH was there. Either
no,
she
PPH
went
is
for
later
any
part. Before that, you should start from the indication now why she has gone, why she has been operated. You told oligohydramnios, okay?
Oligohydramnios. Yes,
yeah.
Sir.
Then, is it important who has done or where it has been done? Does health facilities where she has undergone operation make a difference?
Yes, sir.
Yeah.
District hospital. She underwent on district hospital delivery. So
okay.
It is institutional delivery.
Okay. Because for a woman with previous cesarean, what are the options in this pregnancy?
Sir,
as far as the end outcome is concerned.
She may like again. We'll try for normal vaginal delivery, sir.
Yeah. You are right. You are rightly pointed out because it's not a dictum that if a woman has undergone a cesarean, once a cesarean, it's not always a cesarean.
Yes, sir.
Still, there is an option for a vaginal delivery after cesarean.
Section.
So we can take her for a trial of labor.
Delivery. Yes,
yeah.
Sir.
And if it trial of labor after cesarean, and if you are carefully chosen and monitored and taken for this one, then if she end up with successful TOLAC, then it is called as VBAC. It is vaginal birth after cesarean. It's a retrospective terminology. So VBAC was successful TOLAC. Okay.
Yes, sir.
Or else, if it fails, she'll land up in an emergency cesarean. Okay. So in this background, because that's the reason why I'm asking, because if you want to leave a woman with the previous cesarean for a vaginal delivery in this index pregnancy, so you should know the integrity of her scar.
Yes, sir.
You're right, no?
Yes, sir.
Am I right?
Yes, sir.
So that integrity of scar depends upon what the previous indication.
Yes, sir.
Yeah?
Yes, sir. Like the inter-delivery time should be more than 18 months.
Again, this is one of the important aspects because she has given sufficient time for the uterine scar to heal. So how much is the minimum duration, inter-delivery duration
18,
you would like
18
to expect?
months. 18 months, sir.
You are
minimum.
very good. Yeah. That should be the minimum thing. Okay. Then, so who has done it? If it has been done by if it is daytime or night time, how does it make difference, day or night?
So like,
hello?
Breastfeeding aspect?
No, not breastfeeding. As far as the healing of the wound is concerned. Daytime means sometimes, most of the time, you would have taken her for an elective cesarean.
Yes, sir.
And availability of, if you are considering the institutional delivery, availability of the surgeon.
Yes, sir.
Okay. And okay, and if she has undergone night time, it's an 90% of the time it is an emergency only.
Emergency.
You got it now.
Yes,
So
sir.
resource poor settings and the availability of expert surgeons, this one will be, I mean, minimal. Okay,
At night.
at odd hours of the day. Got it?
Yes, sir.
So there the healing, I mean, you can't guarantee about the integrity of the scar much. In such cases, you can straight away. Can you tell me where are you straight away deciding the woman for a, what is ERCD? ERCD.
Don't know, sir.
Elective? Elective? Srinivas?
No, don't know, sir.
Elective repeat cesarean delivery.
Okay, sir.
Straight away, we are not doing a trial there. So who are all the candidates who can be straight away taken for this ERCD? You already said some of the conditions.
Sir, like
where the vaginal delivery is contraindicated.
No. Yes,
yeah.
Sir. Like contracted pelvis,
very
pelvis,
good.
previous to LSCS.
Okay, because I mean this obstetric and gynecological ACOG, that's national bodies of various countries have come out with the guidelines to leave a woman for a TOLAC.
Yes.
So previous only one lower segment cesarean section can be allowed for a trial of labor.
Delivery.
So yeah, trial of labor. Yeah. So if the woman has undergone two previous
two
sections,
or more.
Yeah, two or more is absolutely she has to be taken for a repeat elective cesarean section only. Okay.
Yes, sir.
Any other conditions technically? Any masses in the lower segment where you can't put?
Yes, sir. Cervical cancer or cervical
cancer. Very good. Yeah. Then?
Sir, any lower genital tract infections.
Okay.
Herpetic viral infections.
Okay.
Like in HIV condition, we'll prefer cesarean section over vaginal delivery.
Okay. To reduce the
risk
vertical
of
transmission.
Vertical transmission, fetus getting HIV should be reduced.
Okay.
Yes, sir.
How about classical cesarean? Here, cesarean section means we are almost 90% of the time talking about the lower segment cesarean section.
Yes, yes, sir.
So how about classical cesarean? Is there any role in the modern obstetrics?
Yeah, yes, sir. We give classical cesarean section, like it will be given midline, sir, straight incision in the upper uterine segment.
Okay.
We give a classical cesarean section in conditions like any mass in the lower uterine segment, like cervical cancer or placenta is other like in previous LSCS, sir. The placenta is not. It will attach wherever, sir. If it is in lower uterine segment, I will ideally give classical incision, sir.
Yeah, adherent
to
placenta.
Prevent blood loss. Adherent placenta. To reduce blood loss.
Various grades of adherent placenta. Okay, then. So how are you? So how do the I mean scar of vertical classical differ from that of a
classic? Yes, sir.
Like why are you worried about the classical cesarean scar?
Sir, yes, sir. Sir, in uterus, upper part and lower part will be there, sir. In upper part, more receptor estrogen, oxytocin receptors will be there, sir. Upper part will contract. Upper part will contract more than the lower part, sir.
So they make a difference in terms of integrity of the scar.
Yes, sir.
Okay.
It will be delay in healing, and muscle fiber will take more time to heal. And,
yeah, you are very rightly said, because the upper segment, it's a thick wall, it's a muscle cutting incision.
Yes, sir.
In a lower segment, it is muscle separating
incision.
Okay, because upper segment is again, it's a dynamic one, contracting. Few days after your suturing, again sutures may become loosened and the pockets of hematomas can be there. It can be act as a foci of infection, and it interferes with the very process of healing. Whereas in lower segment, it is very thin, very easily approximated, and again it is quiescent. It is not dynamic as such as the as like that of a classical one. So healing will be almost very good
in lower segment.
Okay. When do you think that the classical will give away?
Sir, in terms of healing, sir.
Yeah, after healing only. No. What is the greatest risk of dealing with the
Uterine-
previous cesarean woman?
Sir,
Why-
in
what are
classical,
you worried about?
more chance of uterine rupture will be there, sir.
Yeah, very good. Because uterine rupture. So uterine rupture can, if unaccounted and unmanaged, it can
The baby
cause
can
catastrophe not only to the baby and the mother also.
mother
So
also.
tend to lose both the
Mother and
lives.
fetus.
So that should
Yes,
not
sir.
happen. They say the healthcare said no woman should. One of the
Die in
human
giving
rights of
birth.
no woman should
No woman to give birth.
sacrifice
die,
her
no woman
life in fulfilling her dream of becoming a
giving birth
motherhood,
to-
because every
Yes, sir.
woman want to be a pregnant, mother sometime or the other. Though we are in the era of 21st century, women are delaying their age of marriage and delaying their age at which they are going to have their family, but still sometime or the other they want to have a baby and become a mother. But the journey from this girlhood to motherhood is not that safe. It's an uphill task. Okay, if something goes wrong, it can end up in a very catastrophe of losing the mother. So this journey can be made safe and productive by the involvement of the family members and the healthcare personnel. Okay, so what is our main aim at the end of each pregnancy?
To prevent
We have a healthy mother and healthy baby. That is our motive. Okay. Proceed.
Next slide, ma'am. History of present pregnancy. First trimester. Pregnancy was spontaneous conception, sir. Pregnancy was detected after 40 days of amenorrhea by doing urine pregnancy test at home and confirmed in district hospital by dating scan at 10 weeks of gestation.
Yeah. So why it is called as dating scan? So these things are very important to assess the gestational age, because sometime or the other in our journey from of pregnancy, we need to intervene for such women now. So for that, the gestational age estimation is very essential. Okay.
Yes, sir. No history of excessive vomiting, that is hyperemesis gravidarum. No history of fever with rashes. No history of any bleeding per vagina. No history of any burning.
What does it suggest if any bleeding per vagina? What are the conditions?
Sir, in first trimester, bleeding causes of bleeding is abortion, sir.
Okay.
Abortion, ectopic pregnancy, and molar pregnancy.
Okay, proceed.
No history of whitish discharge or burning micturition. No history of radiation exposure. No history of drug intake. Folic acid supplementation taken, and the baseline investigation done and found to be normal.
What are can you enumerate the baseline investigations?
So like normal CBC for hemoglobin count and HIV, HBS, AG, syphilis. Like you will do sugar to know whether she's diabetic before pregnant, or that is called.
As far as maternal mortality is concerned, 80% of our maternal deaths are due to, I say it's a mnemonic. I have got out with a mnemonic. APES. A stands for anemia, P, PPH, eclampsia, that is hypertension of pregnancy. Later stage, it can be an eclampsia and sepsis. The one good thing about this thing is 90% of them are preventable. Got it. So, and for diagnosing anemia, simple hemoglobin estimation is sufficient. Okay. So again, anemia is going to interfere with the growth of the baby also if you are not taken care of. Okay. Again, it will also come in the way of operative deliveries, healing. Okay.
Yes, sir.
Proceed.
Next slide, ma'am. Second trimester, ANC visit were 4, and quickening felt at 16th week of gestation, and TD, that is immunization, 2 doses received, 1 dose at 12th week and 2nd dose at 16th week. Iron and calcium supplementation taken.
When was her previous delivery?
Sir, 3 years back.
3 years back.
Yes, sir.
So
like only one if minimum like within 3 years, if she have consumed means only one dose
Yeah,
of
you
TT should be
are
taken.
rightly pointed out, sir. That was I interested. So for the benefit of this one, okay. If she has more than 3 years inter-delivery interval, you need to give
Take
the
2
two
doses.
doses. If it is within the 3 years, so
One
one
dose
dose,
is
one booster
sufficient.
dose is sufficient. Very good.
Yes.
Then
Iron and calcium supplementation taken. No history of bleeding per
when are
vagina.
you going to give iron supplementation in Indian women?
Usually we'll start in second trimester, sir. We'll not give in first
Why?
trimester. We'll give only folic acid in first trimester, sir.
Why you are not
iron,
giving iron in the first
yes.
trimester?
Sir, it will worsen the condition of vomiting. It will cause more side effects like gastritis. It will aggravate hyperemesis gravidarum condition, sir. It will cause gastritis.
No, these are very mild. What do you say? Mild problems of iron. But what is the one good? Worst? It is teratogenic. What is mean by teratogenic?
Sir, it will cause congenital anomalies in the baby, sir.
Yeah, teratogen. So drug causing. Because the first 12 to 14 weeks is the period of organogenesis. As such, there is no added higher iron requirement in the first trimester. Okay, so there is no need, there is no higher requirement, so no need to give. And again,
iron.
The one contraindication for that is because of it teratogenicity, we are not giving, not the increasing symptomatology. And okay, those are minor, but major is the teratogenicity. Okay, so how much, as far as the government of India is concerned, how much supplementation we are giving? How much iron? How much this one? Folic acid?
For before like in pregnancy period, minimum 180 days iron should be taken, sir. After pregnancy, 100 days.
Again, you are going for a minimum status. Why are you going for a minimum? You start with whatever it is needed. Okay, based on our hemoglobin also.
Yes, sir.
Okay. At least, because what they say is at least she should have taken for at least 180 days. Okay. Yes, okay. Then how much is the elemental iron in each tablet?
60 milligram.
60 mg, it was previous one. Now it is 100 mg elemental iron. Yes. And how much folic acid?
Sir, 400 microgram if she is not having any history of anencephaly baby, sir. If she is having like 4 milligram will give, sir. Like tablet is available.
No, requirement of folic acid as such is only 400 micrograms, as you rightly said. But we don't have 400 micrograms tablets in the market.
500 micrograms.
Because as you said in the first time, so we are going to give only folic acid. It won't come in the microgram strength. It comes in the milligram strength only.
500 milligram.
5 mg tablet is there. Okay. In combination also, that is the given. What is preconceptional folic acid? Have you heard?
Yes, sir. Like to prevent anencephaly baby, sir, before conception, she should start taking folic acid, sir.
Okay.
Before conception.
Since when?
Before conception, 1 to 2 months, 3 months before.
3 months. Yeah, you are very right. At least she should start 3 months prior to her planned conception. Okay, very good. Then,
sir, no history of bleeding per vagina.
Okay.
To rule out APH.
Okay, yeah, very good. So, what are the common conditions that APH?
Placenta previa and abruptio placenta.
Very good. Then,
no symptoms suggestive of preeclampsia, that is excess weight gain, swelling of feet.
How much weight gain is excess weight gain?
Sir, normal Indian, if she is not obese and all normal, sir, 9 to 12 kgs expected weight gain, sir. Normal. That
is overall antenatal period you are telling. As far as, because she'll be coming for your antenatal checkup now. That is not going to be a screening procedure.
Yes, sir.
So per week, how much?
Sir, first trimester 1 kg, second trimester 5 kg, third trimester 5 kg.
Yeah, very good. So that around comes around how many? If you boil down to weekly, how many kgs per week?
A week, sir. More than 2 kg.
2 kgs per week. 12 weeks. 0.5 kg.
Yes.
0.5 into 12 is a 6 week. Again, it is the 6 kgs. As you said in each trimester now. Again, here also, as far as the weight is concerned, first trimester, you don't have much increase in the weight.
Only 1 kg.
Okay. So
Yes, sir.
90% is shared between the second and third trimester only. Okay. So
Yes, sir.
that weight gain is rapid weight gain is again one of the screening methods to know if she is going for a preeclampsia. Okay. Then
Anomaly scan done at 20th week, sir, and told to be normal. NT scan we'll do to rule out Down syndrome, sir. It will be done around 11 weeks.
why is it necessary to rule out the anomalies?
Sir, we'll do anomaly scan to detect any anomalies in the fetus, sir. Before,
Okay.
if you detect any anomaly in the fetus, we can terminate the pregnancy, sir.
Terminate pregnancy. Because again, just anomaly is not sufficient. Whether it is compatible with life or non-compatible with life,
compatible
that matters. And
Yes,
for
sir.
a non-compatible life conditions, you need to
Terminate the
intervene for a
pregnancy.
milder variety. You are not going to do give her a scar, okay, and she can be allowed for a vaginal delivery at the earliest. You are not going to prolong that, like anencephaly and whatever it is, okay. How early can we detect the anencephaly? How early?
Sir,
Approximately.
10 to 11 weeks.
Yeah, very good. That's what I was. The early part of later part of first trimester, early part of second trimester. You not have to wait because sometimes anencephaly babies can go on for a post datism. You do not have to worry because in this era of what you say radiological progress and so many gadgets are there. You should not. You are not afford to leave a woman with anencephaly till the term and beyond. Okay, you have to diagnose it at the earliest so that we can terminate that given pregnancy because it is incompatible with life. Got it? Yeah. Proceed.
Yes, sir. Weight gain is 4 kgs. Next slide, ma'am.
Then
third trimester, number of ANC visit 5, fetal movement pursued adequately, iron and calcium supplementation continued.
What is DFMC?
Sir?
DFMC?
Daily fetal movements count. Daily fetal movements count.
Yeah. So how many counts
Sir,
is sufficient
daily,
for
like daily before regularly she should check up.
No,
check, sir,
regularly
like,
means how many? She will ask you suggest your woman that you should look into
daily
number of count. So she'll definitely ask, sir, how many counts per day is a normal one?
Sir, 8 to 10.
Which one? Daily?
8 to 10 per day.
Yeah, very good. 10. There are different scores, Sadowski scoring, that thing, but on an average, every hour, at least one in a day period, she should have
before eating
one fetal kick for an hour, at least 10 counts per a day. So if she is alarming, perceiving the fetal count less than this count, she should report to you, okay, at the earliest.
Warning signs.
So to pick up the problems early so that we can intervene early to save the baby. Okay, proceed.
No history of bleeding per vagina, no history of leaking per vagina, no history of pain abdomen, no history of increase of frequency of micturition. Growth scan done at 32 weeks and told to be normal. Weight gain is 4 kg.
What are the details you want to know in a third trimester scan? What are the important
sir,
details you want to know from the radiologist?
Sir, like abdominal circumference, femoral length.
Ultrasound, abdominal circumference, you are going to calculate, measure with the tape. No, as far as the radiology is concerned, ultrasound, what are all the important aspects you want to pick from that report?
Fetal.
One thing, you told growth, how it is faring, growth of the baby. Then one more event, this one, Leica volume. What happens to Leica volume as the
decreases,
term progresses?
decreases.
In years term.
It is maximum at 32 to 34 weeks, sir.
Very good.
And again, it will goes on continuously decreases, sir. The rate of
Okay.
synthesis is 500
So
ml per
you
hour,
said
sir.
this woman undergone oligohydramnios. What is
Previously,
oligohydramnios?
sir, it is a condition where amniotic liquor will be fluid will be less than 200 milliliters, sir.
2 or 500? 2 or 500? 200 is very less, huh?
500, either 200.
Less than 500 ml or
500.
single pocket.
Vertical
AFI,
single less
AFI.
than,
What is AFI?
sir, amniotic fluid index, sir.
Index,
will measure
yes.
it will be measured through on USG, sir. Like
Ah.
from 4 quadrant, we'll take
Yes, very good.
single largest vertical pocket will take, sir. We'll add up in the all four quadrant. If it
Very
is
good.
if it is less than 5, sir, we'll call as oligohydramnios.
Yes.
And single largest vertical pocket less than 2 centimeter, we'll call it as oligohydramnios.
So you're very rightly said. So can you tell me what are the common conditions which can cause oligohydramnios?
Sir, any conditions like fetal renal condition will cause oligohydramnios, sir. It is a fetal condition. In maternal conditions like uteroplacental insufficiency will leads into oligohydramnios, sir. In the earlier part, in the earlier
No,
first
uteroplacental
trimester,
insufficiency. What are the clinical condition? Common clinical condition for the mother?
sir, eclampsia,
Yes, hypertensive
preeclampsia.
disorders of pregnancy. Okay,
Yes, sir.
HDP. Okay,
Yes, sir.
preeclampsia and eclampsia. Then
Renal defects like syndromes,
Okay.
kidney will
Proceed.
be not developed.
Okay,
Yes,
you go
sir.
ahead.
Next slide, ma'am.
Yeah, next slide.
Marital history: married at the age of 23 years, and it is a non-consanguineous marriage.
Why is it important? Yes, age of a pregnant lady.
Like early pregnancy and elderly pregnancy, both are risk factors, sir.
Yeah, very good. That is
if
teenage
it is,
pregnancy and elderly. Okay.
Elderly, like
No,
more than
how early?
35.
Till what age you call it as a teenage pregnancy?
18 years.
It is there in the terminology only.
18, sir.
Teen is not there in 19?
19.
Till 19. Okay. Then
Okay, sir.
when do you say
Elderly-
she is elderly? Primi? Beyond?
Sir, more 35, 40 years.
Yeah. Very good. Beyond 35
More is-
weeks. 35
more is
years
for-
of age. Okay.
Yes, sir.
Because all the obstetric complications will be multiplied if the woman is at this extremes of age. Okay.
Yes, sir.
Okay. We should be very, very careful when we are dealing with such woman, a teenage pregnant lady or elderly pregnant lady. Okay. Why is it consanguinity is important?
Sir, like some genetic factors will twins.
Yeah, tell me. Sorry.
Sir, congenital anomalies.
Yeah, very good.
It should
So
should
if-
remain family.
What is first degree consanguinity? What is second degree? Which is more harmful?
First degree is more harmful.
Harmful. Okay. Okay,
Next
proceed.
slide, ma'am.
Next slide.
Obstetric history. Age
Okay.
during first pregnancy is 24 years. It was spontaneous conception. She was a booked and immunized. No history of complication during antenatal period, like preeclampsia, diabetes mellitus, and antepartum hemorrhage. No history of any blood transfusions. Place of delivery.
What does it suggest? Why did you ask for a transfusion history?
Sir, like post PPH to rule PPH.
Sir, good evening. Sir, ಹೇಳಿ sir. ಆಯ್ತು ಸರ್ ಮುಗಿಸ್ತೀನಿ. ಆಯ್ತು ಸರ್ ಮುಗಿಸ್ತೀನಿ. ಓಕೆ ಥ್ಯಾಂಕ್ ಯು. ಆಯ್ತು ಸರ್ ಮಾಡಿಸ್ತೀನಿ ಸರ್.
Yes, sir. Sir, like to know the condition like PPH, the amount of blood loss.
In the previous
Like-
program, because
Yes, sir. Like if she has
again
lost
it mean to
anemia.
say sometimes that the operation has been done in the night time, okay, as an emergency basis, got it. Sometimes a junior consultant might have done it, got it. So again it all goes on to say that the integrity of the scar in that previous pregnancy. So based on all this history, you want to leave this woman for a trial of labor or not, you are going to come to the conclusion. Okay, proceed.
Yes, sir. Place of delivery, District Hospital, Gulbarga. Delivered by
Okay.
elective lower segment cesarean section due to oligohydramnios at 38 weeks of gestation. The baby is live birth, term baby, male child. Birth of weight birth of male child baby is 3 kg. Cried immediately after birth.
Okay, then
Next slide, ma'am. No history of NICU admission. Breastfeeding started within 4 hours after birth. Exclusively breastfeeding given for 6 months. The baby currently healthy.
no. I mean, as far as the breastfeeding is concerned, is 4 hours. Is
Sir,
that
adequately-
what is the recommendation?
Sir, as soon as she should, like within 30 minutes to 1 hour, she should start breastfeeding, sir.
Yeah, in a normal delivery, she should
30
start
minutes
within
to
half
1
an
hour.
hour to 1 hour.
1 hour.
Okay,
LSS
because
up
they
to
say
2
that
years.
with this simple intervention of initiating a breastfeeding within half an hour of delivery, you can save 1 million babies. You got it, because of its what is the benefits of the breast milk. So such is the importance. This 4 hours was one time set, because most of the time in the previous years they used to deliver by general anesthesia. So for a woman to get out of the general anesthesia, she should have taken this many hours. But in the modern obstetrics, very few indications are there where we are using general anesthesia. So most of the time here now we are using regional anesthesia. Either it could be subarachnoid block or epidural anesthesia, where almost woman is awake. Okay, so we are anesthetizing her below the level of umbilicus, where the area of our operation is there. So absolutely she is in her senses. So as early as possible she can breastfeed. Okay.
Exclusively
What is exclusive breastfeeding?
Sir, like she should give only breastfeeding, only breast milk for up to 6 months, sir.
Up to, yeah, you're right. Only breast milk only. Okay.
Up to 6
No
months.
top feeds, no prelactal feeds. Got it? Yeah.
Yes, sir. Currently baby is healthy, immunized, up to date, and baby is doing well, sir. No history of purpural complications like fever, foul smelling, lochia, wound gaping, wound discharge, resuturing, or
What does it suggest? What does this suggest?
Postpartum hemorrhage.
No, not only hemorrhage. You are selling false smelling lochia will come in when?
Sorry, purpural sepsis.
Sepsis, infection. Okay, again it interferes with your scar healing.
Wound healing. Healing.
So if she has got these indications, if she has got these things in her history, so you are not going to leave her for a trial of labor, because the integrity of scar is not guaranteed. Okay,
yes, sir.
Because endometriosis, false smelling lochia is due to endometritis. Okay, and prolonged hospitalization also. Okay.
Yes, sir. Suture removed on 8th day after delivery, discharged the next day.
How does it makes difference?
Sir, suture removal, sir.
Yeah.
Usually we'll 7 to 2 in LSCS, we'll remove 7th to 8th day after delivery, sir.
Okay.
Yes, sir.
So you are more worried about if she has, prolonged stay in the hospital post-operatively. By max 7 or 8 days, she should go home with the sutures being removed. Or if she had stayed for a long time, only when she is having a discharge from the wound, again, it would have been given up. You would have given a secondary suturing. Sometimes, very rarely, tertiary suturing may also have been given for her. So such women are again not a good candidates for your trial of labor.
Normal budget.
Yeah,
Style of labor.
proceed.
Sir, no history of wound gaping or infection.
Yeah.
Present age
Okay.
of child is 3 years. And history of use of contraceptive in the form of intrauterine device, copper device for the next 2 years.
Was it taken intervally or what is PPICD?
Postpartum insertion of IUCD.
Yeah, the current government of India's recommendation is that one, because got it now immediately postpartum, that is post placental expulsion. You can put a
Insert
intrauterine contraceptive device, whether
yes,
during a cesarean or even whether
normal
during a
vaginal.
normal delivery or even during
LS,
cesarean
yes.
section. Okay, then
Menstrual history. LMP
Okay.
15/3/2022, EDT 22 December 2022. Age of, at monarch is 40 years. Menstrual cycle regular 28-day cycles. Flow lasting for 4 days. Changes 2 parts per day. No dysmenorrhea are not associated with clots.
yeah, as you discussed previously, she fits into a regular cycles. So her LMP, what the date she has given is could be good to excellent also.
Yes, sir. Next slide, ma'am. Past history. No history of diabetes, hypertension, tuberculosis, bronchial asthma, or thyroid disorders. No history of any other surgeries in the past. No history of blood transfusion. No history of
Do
sexually
we
transmitted.
screen for a diabetes in pregnancy? Routinely?
Yes, sir.
Recommendation?
Yes.
GDM?
Yes, sir.
Okay, because again it interferes with the management and prolongation of gestational pregnancy.
Yes, sir.
If it is uncontrolled, you need to give need to intervene at the early.
Earliest, before 2 weeks.
Yeah.
At 38th or 39th week of gestation.
Okay, proceed.
Next slide, ma'am. Personal history. She consumes mixed diet, normal bowel and bladder habits, normal sleep. She's not having any addictions, and no history of any drug intake or allergy to any drugs. Family history. No history of any diabetes, hypertension, TB among family members. No history of multiple pregnancies, congenital anomalies in the families.
Okay.
Next slide. Examination, sir. General examination. Patient was well built, moderately nourished, well oriented to time, place, and person. Height is 155 centimeter, weight 48 kg, and BMI.
As far as the height is concerned, when do you call it her as a short stature?
Less than 145 centimeters.
Oh, very good. Okay.
No gait or any spinal deformities, and no pallor, icterus, cyanosis, clubbing.
Why do you want to examine breast, spine? This one?
Sir, thyroid.
Thyroid.
Sir, it, like spinal defects, will not be able to give anesthesia, sir.
Oh, yeah.
Thyroid hypothyroidism will cause in baby congenital hypothyroidism. It may lead, sir. It may lead into.
So you need to screen for it and treat appropriately. Okay, during the pregnancy.
Yes, sir.
Then why breast examination is important? Is it? Do you think it's a part and parcel of antenatal checkup or not?
Yes, sir. It is important.
When do you examine breast exactly in a pregnancy? After delivery or after initiating breastfeeding?
After delivery. Like before initiating or at any time, sir, like nipple retraction to check whether it is a nipple retraction or anything, it will interfere in feeding.
Breast examination should start from the initial visit only, because there are few conditions you have to pick up. This, as you said, rightly said, nipple retraction, cracked nipple, those conditions need to be treated prior to initiation of breastfeeding, or else if you wait till the delivery and ask her to start breastfeed, she won't be able to feed. Okay, yes, because you are not looking to the breast and the treatable minor conditions of a breast. Okay, yes, so breast examination start from the very first antenatal visit only.
Yes, sir.
Okay, then.
No pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema, sir.
Okay, proceed.
Next slide, ma'am.
If she is pale, you need to, anemia has to be picked up because she is already a previous cesarean section woman. She might land up anytime again, repeat cesarean.
Yes,
Okay,
sir.
then you need to correct her hemoglobin levels prior to term and
delivery.
before going for labor. Okay, then.
Yes, sir. Thyroid examination normal, breast examination normal, systemic examination, cardiovascular system, S1, S2 heard and no murmurs, respiratory system, normal vesicular blood sound heard and no added sounds. Next slide, ma'am.
Okay.
Vitals, she is afebrile on touch, pulse rate is 84 per minute, regular in rhythm, normal in volume and normal in character, and all the peripheral pulses are felt and no radial and no radiofemoral delay. Respiratory rates are 18 cycles per minute and blood pressure 120/80 measured in right upper arm in sitting position.
Very good. Okay, absolutely. Vitals are stable.
Yes, sir.
Okay.
Obstructive abdominal examination inspection. Abdomen is uniformly distended. Flanks are not full. Umbilicus
what does it mean?
Sir, it is like it is not in like
Term. Okay.
Term. Umbilicus is in midline and everted. Linea nigra, stria gravidarum, stria albicans are present. Healthy horizontal scar of approximate length of 10 centimeter, present 2 fingers breadth above the pubic hairline, healed by primary intention.
Do you have any name for that incision?
Yes, sir. Phalansteal incision.
Yeah, very good. Then proceed.
Cuff impulse at scar site and hernial orifice are not present. No visible pulsation, peristalsis, dilated veins, scar sign, sinuses over the abdomen. Palpation, fundal height 36 weeks correspond to period of gestation. Symphyso fundal height 36 centimeter. Fundal grip, first pelvic grip.
Why is it important, fundal height? Again, what is the importance of fundal height?
Sir, we can estimate delivery and we come to know period of gestation.
Again, it's one of the method of gestational age estimation also. What is gravidogram?
Sir, used to measure the weight of gestation.
Okay.
Like fundal height, sir.
Yeah, in centimeters beyond.
Yes, sir. In at uterus.
Beyond 28 weeks, it corresponds to in centimeters. If
yes,
it is
sir.
32 centimeter, again, it is corresponding to 32 weeks
of gestation.
Gestation.
Yes, sir.
Okay. Sometimes it can be falsely large, falsely small. Where?
Falsely small in oligohydramnios, sir.
Yeah,
large
very good.
In polyhydramnios.
Yeah,
large
very
in polyhydramnios.
Okay, we should keep it in mind. Okay.
Yes, sir. Sir, uterus on 20th week it is below umbilicus, 24 weeks above umbilicus, and every 3 centimeter 4 weeks will be there, sir. 36 GV sternum, and again it will come down, sir, at 40th weeks. She'll complain like relieved of respiratory symptoms.
What do you call that phenomena?
Welcome sign or lightning.
Lightning, yeah, very good.
Yes, sir. And next, for fundal grip, soft, broad, irregular, non-palatable mass, suggestive of breech. Lateral grip, right side, irregular knob-like structure felt, suggestive of limbs. Left side, uniformly curved, smooth, resistant felt, suggestive of spine. First pelvic grip, hard, globular, palatable mass, suggestive of fetal head, not engaged. Second pelvic grip, hands converging, head is not engaged, it is cephalic presentation.
That is sufficient, or anything more you want to have in palpation? Because it's a cephalic presentation, longitudinal lie and cephalic presentation. Do you want to know the attitude of the head?
Yes, sir. PV examination.
No. During abdominal examination only, attitude of the head.
Yes, sir.
Does it make sense?
Yes, sir.
If it is flexed or deflexed or extended?
Yes, sir.
No. Head, if his fetal head is flexed or deflexed or extended. How do you know if it is flexed or normally it should be? The baby is in the uterus, baby, the position is universal flexion, flexion at all
Yes, sir.
joints. Na?
Yes, sir.
Definitely, flexion head is the favorable one.
Yes,
So
sir.
how do you say it is? This head is flexed. For that, you should know sinciput and occiput.
Occiput, yes, sir. Sinciput, it is between root of the nose to the anterior fontanelle, sir. Occiput
Okay.
from posterior fontanelle to the occiput, sir.
Very good. If
In
so,
between
what is
anterior
what is their relation in flexed head, deflexed head, and extended head?
Yes, sir. Per abdomen, occiput will be felt in flexion, sir. Per abdomen examination.
So occiput is lower level than
Lower
the
level.
sinciput.
Sinciput,
Okay.
sinciput will be an upper level.
Okay.
And
So in a
extended,
deflexed, they are at the same level.
opposite.
Okay.
Yeah.
No, same level only. They come in the
Deflex
same
sir.
line. Okay. In extended head,
Opposite. Sinciput will be on lower side, occiput will be upper side.
yeah, that is again the presentation could be bro or face presentation.
Yes, sir.
Okay. So those are the difficult vaginal delivery cases. Okay.
Yes, sir.
Such conditions with the previous history of cesarean, straight away you can go for a
LS.
repeat cesarean section once
section.
the viability of,
Cross
baby is,
grade of
viable.
yes, sir.
Okay.
Scar tenderness absent, sir. Uterine activity is relaxed.
How do you look for a scar tenderness?
Sir, will
Which scar you are worried about?
Sir, lower uterine segment, skin incision we are given, that scar.
No. You are worried about abdominal scar or uterine scar?
Uterine scar.
Uterine scar, very rightly. Yeah. So how do you look for uterine scar? Because these days, most of the time, we are doing lower segments, cesarean section only. Very rarely, upper segment or what do you say, extension of lower segments, like J shape or inverted T, very, very rarely. Okay.
Yes,
so how do you look for a scar tenderness in a lower segment cesarean section?
First, we'll deviate her, sir. Like we'll talk anything and we'll touch.
So our attention should be deviated to the other thing. Okay.
Yes, sir. And we'll palpate on that area. If suddenly she
what should be the what should be our what is that like this one position of legs? Abdominal,
flexed, sir. Dorsal position, knees and hips are flexed, sir, so that the abdominal muscle should be relaxed.
Yeah, definitely. Okay.
We'll palpate, sir. We'll look for any in her face, wincing effect of the mother.
Okay, what does it suggest if scar tenderness is press?
Sir, more chance of rupture.
Going for a rupture. Okay. What is dehiscence and what is rupture?
Sir, scar dehiscence, serosal layer will be intact, sir. It's an incomplete rupture, sir. In scar rupture, the layer is serosal layer is also ruptured. More chance of uterine rupture, sir. In scar dehiscence, we can have time so that we can take her to the OT and we can do the delivery. So scar rupture is an emergency condition.
Okay. So the idea of monitoring the woman with previous cesarean in labor is to look for the early signs of dehiscence. You should not leave her for a rupture.
Yes,
if at all she has already landed to you in your clinic or in the hospital in a ruptured status, that is the altogether different scenario. So when she is in your care, she should not go for a rupture. You should pick the early signs. So what are the signs which say that she might have ruptured?
Sir,
what are the symptoms and signs?
Fetal
maybe
heart
she has
rate
ruptured.
Fetal heart rate is increasing.
Okay. So variation in fetal heart rate. Okay.
Heart rate, sir.
Okay.
The uterus size is
CTG tracing. Okay. Then
cardiotopogram variation, sir.
Okay. Then
on non-stress test, NST will do.
Why now? NST. NST is not needed. It's a antenatal surveillance procedure. NST is not done now. Okay.
Yes, sir.
Okay. One thing. The fetal okay.
Fetal
variation in fetal heart rate. How about maternal pulse?
Yes, sir.
If she has ruptured?
she'll show the feature of shock.
Yeah, shock, tachycardia, shock. Okay, then
Yes, sir.
does she, if all this time she was screaming with the pains, okay, all of a sudden she is relieved of pain. What does that
Pain.
mean? She might have
Ruptured.
ruptured.
Ruptured the uterus.
Cessation of pain.
Yes, sir.
Got it?
Yes, sir.
And as far as the pelvic examination is concerned, recession of presenting part. Recession of presenting part. What it was previously, as the labor and delivery progresses, there is subsequent, I mean, what is say, successive descent of the presenting part should be there. Here again,
Yes,
recession of the presenting part can occur.
Yes, sir.
Got it? Okay.
Yes, sir.
Then again, on abdominal examination, what happens?
For fluid in the peritoneum.
No, whatever, easy palpation of fetal parts. Contour
yes,
is
sir.
lost. Contour is lost. And easy palpation of fetal parts. Again, loss of fetal heart rate, because baby is going to succumb once the uterus is given away. So when because the what is the function of uterus is to, during labor and delivery, it has to contract and push the present, I mean, contents into any of the
lower
outlets. It is not going to differentiate whether it is through the cervix or through the uterine scar which has given away. Okay, so easiest way is through the uterine scar incision. It is get into the abdominal cavity. Again, baby is going to succumb.
Yes, sir.
Okay, then
liquor is
anything you can observe in the urine.
Yes, sir. Color of the, like it will be green stained or any other color.
Red. Hematuria can be a sign of dehiscence or rupture. Okay.
Yes,
okay.
sir.
Then proceed.
Yes, sir. On auscultation, fetal heart rate is 144 beats per minute in left spino-umbilical line, and it is regular, sir.
Okay.
Next slide, ma'am. Summary, sir. Mrs. Veena, 27-year-old, gravided to para-1 living one with the last menstrual period on 15th March 2022, EDD on 22nd December 2022, with 37 weeks and 4 days of gestation, is admitted in hospital with history of previous cesarean section done in view of oligohydramnios. Currently, she pursues normal fetal movements and not in labor. Obstetric examination reveals a term-size uterus with singleton live fetus in cephalic presentation. Head is not engaged and there are no scar tenderness.
Okay, what do you want to do now for her? What does the literature say? When are you going to intervene in a previous cesarean section case? If everything is normal,
1 week less
what
than
gestational age you can wait for the spontaneous onset?
We'll wait up to the spontaneous onset of labor takes place, sir.
Because there is nothing like nature is the perfect healer.
Yes, sir.
Okay, so it has got this one. So there is nothing like the woman going for a spontaneous onset. So that's the reason you can remember. You have previously asked her where is her health facility. If she is very near to the health facility, she can be allowed to go till the onset of labor pains. Or else, if she is far away from the health facilities, we can admit her 1 or 2 weeks prior to the expected, that is 39 weeks. Beyond 39 weeks, I mean, we are not waiting at least till 39 weeks. So at 39 weeks, you can go for a electrorepeat cesarean section when you are not sure about the integrity of the scar, or else she can be very, if everything is normal, low risk, you can very well take her for a trial of labor. Okay.
Yes, sir.
Then, so what is more important when we are taking her for a trial of labor? Informed consent. These days, this is an era of litigations. You need to be protective of yourself. You need to take not only this case, in every medicine, in a healthcare condition, you need to take for written informed consent from the written and informed consent about the process we are going to do on them and its pros and consequences. Okay.
Yes, sir.
So you should be very well, she should be very well informed about the problems of leaving her for a trial of labor and the risk of rupture. Okay.
Yes, sir. Yes, sir.
Do you know the incidence of rupture in previous one section, previous two sections?
As the pregnancy increases, more chance of ruptures. Hello.
Sir is disconnected with audio. We'll wait.
Yeah, Sinos?
Sir.
Yeah.
Hello.
Yeah, tell me, I'm able to hear you.
Yes, sir.
Yeah. So what do you want to do for her now?
Sir, we'll monitor and we'll wait for the labor to spontaneous onset of labor to occur.
Okay, because our health facility is only 15 minutes.
Yes, sir. Hello. Hello.
Sir got disconnected. 1 minute, we'll wait.
Yes.
Srinivas?
Yes, sir.
Srinivas?
Yes, sir.
Yeah. Is this your last slide?
Yes, sir.
Okay. So when do you want to deliver her now?
Sir, we'll wait up till 39 week of gestation, sir.
Okay. You want
We'll
to
wait for
take her for a TOLAC or not?
Sir, we'll wait. We'll check whether needed or not, sir. If it is a recurrent condition, we'll take, sir. If everything is monitored well, we'll wait up to the labor to onset spontaneous, sir. If there is no scar reductions or tenderness. Hello.
Sanjana, madam.
Hello? Hello?
Hello. Hello, sir.
Srinivas?
Yes, sir. Audible.
Yes, sir. We can hear you, sir, but it's getting disconnected, your audio, sir.
Madhusudan, sir? Pooja?
Just a minute, sir.
Yeah.
Sir, it's audible, sir.
Yeah.
Need to wind up, I think. There is one more meeting. Can you hear me?
Yes, sir, we can hear you.
Yeah. Pooja? Hello, we can't hear you, Pooja.
We can't hear her.
Unmute.
Yeah, yes, sir, it's audible.
Yeah. Yeah, we need to wind up. Ramraj.
Sir, am I audible, sir?
You're audible, Pooja. Go ahead.
Yes,
Yeah,
sir.
tell
I'll
me.
just find it, yes, sir. Yes,
Tell me,
sir.
Pooja.
Thank you, sir.
Ah,
Yes, sir. Should I wind it up, sir? Is Hemraju sir in the meeting?
okay, thank you so much for the opportunity, and I thank every.
Sir, I'll
There is a
present the
network
vote of
issue.
thanks.
Ramraj.
No problem.
Just a minute. Dr. Sanjana Patil is there, academic committee chairman. She just
Hello.
Yeah, Madam Heli.
Sure, sir.
Sir, I would like Dr. Pooja to give few advices. See, as the participants are less, kindly make more flyers or whatever is available and make more students to join this platform.
Yes, sir. Yes, sir. Yes, ma'am. We'll definitely work on this
You work
in
on
our
this?
upcoming sessions. Yes.
Because you send the flyers to all the medical colleges, so many people will join the platform.
Yes, ma'am.
Okay.
Thank you.
And make it before itself. Don't put a flyer one day before. It won't be possible for them to join. Okay. Let it be 1 week
Yes,
before,
yes,
so that
ma'am.
it will circulate everywhere in the Karnataka and many will join. The interior persons like Gadag Medical College, Hassan Medical College, Bidar Medical College, all these colleges will join. The young budding, which are new medical colleges, they'll get a facility to join if you circulate among everyone. You see,
Yes,
the
yes, ma'am,
attendance is
definitely.
only 30.
Ma'am,
There are so many medical colleges in our state, right? So that interest you should take on.
Don't get disappointed,
yes,
Pooja.
yes, ma'am. We'll definitely work on
Don't
it.
get disappointed.
No, sir. We'll
But
no, sir.
This is only 1 day effort, madam.
Yes.
sir, I know I have talked with her, sir.
Yeah. This is within 1 day, 30 is a very
ಇಲ್ಲ
good
ನಾನು
number.
ಮಾತಾಡಿನಿ sir ಅವಳ ಜೊತೆ I have talked with her.
Yeah, that's what I said. Within 1 day, 30 is a very good number.
Put a more effort, okay?
Yes, ma'am. Thank you for your insight, ma'am. On our next session next week, we'll definitely
Take some
have
medicine
more
cases,
participants.
surgical cases, and even the
Yes, ma'am.
Ophtho ENT SPM people are also writing exams. So let them
Yes,
also
ma'am.
present the cases. Okay?
Yes, ma'am. Sure. Yes, ma'am. Thank you. I'll conclude. Thank you, sir. I would like to take this opportunity to convey our heartfelt gratitude towards Dr. H.E. Ramaraju, sir. Sir, are you in the meeting? Is he there, sir?
No, sir, audio is disconnected. You go ahead, Pooja.
Okay. Regards to Dr. H.E. Ramaraju, sir, thank you so much for giving us your precious time. Your advice and guidance is definitely going to be one we can rely on and help us immensely for our upcoming exams. On behalf of IMA KSB, Academic Subcommittee, and IMA MSN Karnataka, I would like to sincerely thank you. I would like to extend my gratitude to Dr. Shivkumar Lokal, sir, President IMA KSB, for his gracious presence today. Dr. Karnakar, sir, Honorary State Secretary. Dr. Madhusudan, sir, Immediate Past President IMA KSB. Dr. Vijay Sarthi, sir, Honorable State Treasurer. Dr. Shubhrata, ma'am, IMA Coordinator. Dr. Arjun C, Chairman, IMA MSN Karnataka. I would like to extend my gratitude for their immense support. I would like to thank Dr. Sanjana Talur, ma'am, to have joined us today. I would like to extend our special thanks and gratitude towards Dr. Madhusudan, sir, for your continuous support and guidance. We could only organize this session due to your intervention and support, sir. I would like to appreciate and thank Srinivas Reddy for his excellent presentation, and thank Mithun, State Convener, IMA MSN Karnataka, and all the members of IMA for their tedious efforts, which truly made this event a success. Over to you, Mithun. Thank you so much.
Thank you, Pooja. Thank you everyone for joining. As due to internal and other reasons, we were short of students. But however, Dr. Madhusudan sir and our IMA KSB and IMA Academic Subcommittee team and all the IMA KSB has made us so much efforts that the present session which went on is also recorded, and it will be uploaded in a YouTube channel also, which will be shared in all our WhatsApp groups. So those who were unable to attend this session due to certain reasons can watch the same session in the recorded channel of our YouTube. Thank you. Thank you, Pooja, for live streaming the session and making in all the efforts. Thank you. Thank you, everyone.
You share the link also to the students, okay?
Ma'am, yes, ma'am. It is already shared in our group.
Yes, ma'am. We'll share the
So-
link.
Oh, okay.
Dr. Madhusudan.
Thank you, everyone, for joining us today.